So now we'll start with lymph nodes. So this is a part of a network of a lymph vessels that extend throughout the body. So lymph nodes are present throughout the body. The clear yellow fluid that flows is called as lymph. Okay? During this journey, lymph is filtered through lymph nodes, and these nodes are filled with white blood cells that are lymphocytes. In peripheral blood here also. In blood also lymphocytes are present, and they are also present in the lymph. Okay, so this is there are other lymphoid organs in the body, such as lymph nodes. Yeah, they are present everywhere in the body. Tonsils are also lymphoid organs. Bone marrow, spleen, liver, lung, and intestine also has lymphoid tissue in that. Today is the topic. Today we are discussing about lymph node. So how lymph node will look? It is a bean-shaped or oval in shape, and the size of the lymph node will be 1 to 2 centimeters in diameter, and it is a part of lymphatic network. And the lymph nodes are surrounded by a connective tissue capsule. So this is a general normal morphology of the lymph node. So now what are the structures inside the lymph node? So now we'll see what are the structures of the lymph node. When we cut open the lymph node, so we will see a fibrous lymph node surrounded by a fibrous capsule, and inside the lymph node, capsule, So now the lymph nodes have a capsule inside that, and this capsule extends into the lymph node and forms trabeculum. The confluent side of the lymph node is called as the hilum. Okay? The arteries and veins that attach at the hilum, and they allow the blood to enter and leave the organ respectively. The parenchyma of the lymph node, the normal structure of the lymph node is made up of cortex, and outer is the cortex, and inner is the medulla. So, now normal histology of the lymph node. So we have seen outermost is a capsule, which we can see the outside, it is a fibrous connective tissue. Inside the capsule, there is a subcapsular sinuses are present, that is spaces between the capsule and the normal lymph node structure. So our lymph nodes are divided into cortex and medulla. So this is the cortex of the structure, and it has nodules. Okay, so the cortex is made up of nodules. There are two types of nodules, primary and secondary. Okay, so primary nodule is the one which don't have the germinal center. Okay, and the secondary cortical nodule, it has a germinal center in between, that is in this light area. Okay, this is called as germinal center, and if the germinal center is present in the nodule, it is called as a secondary nodule. And there is a mental zone. This is a margin of the germinal center is called as a mental zone. Okay, secondary nodules which have the germinal center, this is a capsule. Trabeculae are the space. This is the capsule which extends into this lymph node. It is called as a trabeculae. Now this is the cortex part is over. Now we'll see the medullary part. So medulla is made up of medullary cords, which is this blue purple color are the medullary cords, and medullary sinus, that is empty spaces between the cords. These are the cortex sinuses. There is a paracortical deep region. So it is a paracortical deep region. This is a region, and where we can see key lymph system. Yeah, and this is these are the medullary cords. So this is the normal histology of the lymph. Now we'll go. So now we'll see the cortex. Okay, so cortex has a subcapsular sinus, which we have seen, that drains to the cortical sinuses. Outer cortex is called as a nodular cortex. Nodules present are predominantly of B cells. Okay, so nodular cortex has B cells in that. Lymphocytes of two types, B cell and T cell. So nodular cortex has B cells, and the paracortex, that is deep cortex, it has T cells. So the cortex is absent in the hilum part. Now we see the medulla. So medulla is the innermost part of the lymph node. There are two main structures, medullary cord and medullary sinus. The medullary cords are cords of lymphatic tissue that includes plasma cells and T cells. Now we'll see medullary sinus. That is, sinus is an empty space. These are the vessel-like spaces separating the medullary cords. Lymph flows to the medullary sinus from the cortical surfaces and then into the afferent lymphatic vessels. So this is a normal circulation. They may become, lymph nodes will become enlarged if there is any tumor or infection. White blood cells are located within the lymph node like a honeycomb lymph node. So the white blood cells, that is WBCs, that are lymphocytes, B cells or T cells are present in the lymph node. And there are centrocytes, centroblasts, lymphoblasts, and immunocytes. So, white blood cell production will be increased if there is lymph node enlarged, if there is an infection. And if white blood cells are increased, the size of the lymph node will increase. This is if the site infection or tumor is present, the size of the lymph node will increase. Now we will see the lymphatic circulations. So there are afferent lymphatic vessels which are coming from the other sides of the lymph, and that drain into the subcapsular sinus. They come from the capsule, enter into the subcapsular sinus, that drains into trabecular sinuses, then into medullary sinus, and that leaves the lymph node via afferent lymphatic vessels. This is the lymphatic circulation. Lymphocytes, both B and T cells, constantly circulate through the lymph. These cells migrate to the nodular cortex and the medulla. Okay, so these cells are mainly present in the nodular cortex and medulla, and these cells migrate to the deep cortex. So this is a normal structure and histology of the lymph node. If there is any antigen, when the lymphocyte recognize the antigen, these cells becomes activated and they migrate to the germinal center. We have discussed prior, the lymph node is called secondary nodule if there is germinal center is present. And if the germinal center is absent, it is called as a primary. Okay, after that, the antibodies are produced by the producing plasma cells are formed and they migrate to the medullary pores. So this is a normal mechanism. So what are the functions of the lymph node? They are important for the immune responses of the body and they act in phagocytosis for the particular material. They do the phagocytic process. Phagocytosis will take place in the lymph node. Now this is a normal lymph node is over. Now we'll see the abnormality. So what is the abnormality in the lymph? What is lymphadenitis? So the lymphadenitis is the inflammation of the lymph node. Lymphadenitis may be either generalized all over the body, all the lymph nodes are inflamed, or it is localized, only particular area is involved. Lymphadenitis is sometimes accompanied by lymphangitis. So what is lymphangitis? It is the inflammation of the lymphatic vessel that connects the lymph node. So there are two terms we discussed: lymphadenitis, that is inflammation of the lymph node, and lymphangitis, that is inflammation of lymphatic vessels. So now the lymphadenitis, when it takes place, either it is inflammatory agent is present, or there is an immune reaction, or there is a primary malignant neoplasm around the lymph node, or metastatic tumor deposited into the lymph node. So there will be inflammation of the lymph node. So what are the causes of lymphadenitis? Mainly the causes are infection or inflammation. So what are the causes for infection? Then streptococcal, staphylococcal, bacterial infection, which is the most common, then the virus, protozoa, rickettsia, fungi. These are also important. Tuberculosis bacilli is the most important cause in India for the lymphadenitis. Cat scratch disease, Lymphogranulomas ramorum, chancroid, genital herpes, in children tonsillitis or bacterial sore throat, infectious mononucleosis, cytomegalovirus, toxoplasmosis, brucellosis are the other infectious causes for the lymphadenitis. What are the symptoms? How the patient will come? So the earliest symptoms, patient will have the swelling of the lymph node. Further, he develops fever, chills, loss of appetite, heavy perspiration, rapid pulse, and generalized. reactive lymphadenitis, that is inflammation of the lymph node. There are two types, either it is acute or chronic, depending upon the duration. So if it is for the small duration, the infection is called as acute lymphadenitis. The repeated patient is having the repeated infection, then it is called as a chronic lymphadenitis. So now we will discuss each of these conditions. Acute non-specific lymphadenitis. Non-specific when we know the cause of the lymph node enlargement. So if in acute lymphadenitis, the causes of microbial infection, the causes we have discussed prior, or the bacterial, viral, parasitic, or fungal viral infection. Then foreign body in the wound, that can also lead to acute non-specific adenitis. So now if the cervical lymph nodes are present and it is acute infection, then the infection is maybe in the oral cavity or teeth. Axillary lymph nodes lymphadenitis indicates infection of arm. Inguinal lymphadenitis is because of the infection of lower extremities, and mesenteric infection is because of any infection in the appendix and colon. So this is an acute. Okay? So if there is acute infection, so what the patient will have? So the nodules lymph nodes will be enlarged and tender in the acute non-specific lymphadenitis. It is extensively involved, and if it is extensively involved, then it will fluctuate. If you can press at one place, then we can see the fluctuation in the lymph node. Overnight skin is red and hot. After control of the infection, it heals completely without showing any scars at that area. So this is the clinical feature for acute lymphadenitis. So how the gross lymph node will see? So the lymph node will be enlarged 2 to 3 times of normal size. It may show an abscess. Okay, after cut opening, you can see pus inside that, or there can be discharging sinus through the skin. So the pus can come out of the skin like from the sinus, okay, from the skin. The infection pus will come out. So now we'll see what is the microscopy of the lymph node, acute lymphadenitis. So the sinusoids are congested as the RBCs will be present in that and widely dilated. They contain numerous neutrophils because it is acute infection, so there will be neutrophils. Lymphoid follicles which we have seen, that is nodular, are prominent and show presence of many mitosis and phagocytosis. And in severe cases, necrosis can be seen. There is necrotic material debris will be present in the lymph node, and neutrophilic acid, that is neutrophils are also present in the lymph node. This is called as acute non-specific lymphadenitis. Now we'll see chronic non-specific lymphadenitis. So what is chronic? That is recurrent infection. Repeated attack of acute lymphadenitis will lead to chronic. So what are the types of the chronic non-specific lymphadenitis? On its histology, they are divided into 4 parts, 4 types. That is follicular hyperplasia, paracortical hyperplasia, sinus histiocytosis, and mixed pattern. So each of this will discuss later. So how the chronic non-specific lymphadenitis lymph node is? So grossly, the lymph nodes are enlarged. Okay, both acute and chronic will have enlargement of the lymph node, and it will be firm. In acute, we have fluctuating lymph nodes, and they were tender. In chronic, the lymph nodes will be tender. Okay, so non-tender lymph nodes present in the chronic lymphadenitis. So now we see follicular hyperplasia. So the name suggests it is follicular hyperplasia. So the follicles are increased in number or larger in size. So what are the causes for it? Non-specific sometimes or specific causes. So follicular hyperplasia is a chronic condition. So some chronic diseases can cause follicular hyperplasia. So what are the chronic conditions? Rheumatoid arthritis, toxoplasmosis, and early stage of HIV infection will have follicular hyperplasia. So now what is the microscopy of the follicular hyperplasia? So enlarged follicles which we have seen primary and secondary will be enlarged. Prominent germinal centers are present. If it is germinal center present, then they are called as secondary follicles. Dark zone which is present will show immunoblasts, and light zone will have cellulosis. Tingible body macrophages which are specifically present in the follicular hyperplasia. What are the tingible body macrophages? These are the macrophages which contain nuclear debris. Okay, so these are present in follicular hyperplasia, and plasma cells, macrophages, neutrophils, and eosinophils can be present. So now we see the diagram of the follicular histology. So this is a follicular hyperplasia. You can see the large follicles, and there is a distension of the germinal centers, and surrounded by there is a mental zone of the lymph nodes. So this is a follicular hyperplasia. It is a chronic condition. Okay, now you can see these are the tangible body macrophages, TBM we have written. So what are that tangible body macrophages? These are macrophages which contain nuclear depth. Okay, so they are present in follicular hyperplasia. So now we'll see second type, that is paracortical lymphoid hyperplasia. Okay, so what is paracortical? We can say that is cortex, below the cortex there is lymphoid hyperplasia. And what are the cells which are present in the paracortex? That are T cells. So hyperplasia of T cells dependent areas of the lymph node, stimuli that activate a cellular immune response. So which they activate the cellular immune response, then there will be paracortical lymphoid hyperplasia. What the causes for that? With immunological reaction caused by drugs like dilantin or vaccination against viral diseases, viruses such as infectious mononucleosis. Infectious mononucleosis is caused by Epstein-Barr virus and autoimmune disorders. These causes for the paralymphoid hyperplasia. I hope all of you can hear me. Is there any problem? Okay. So now, what is the microscopy of the paracortical lymphoid hyperplasia? So microscopy, there is expansion of the paracortex. So paracortex will be expanded. Immunoblast T cells will be present because it is paracortex, so T cells will be present. Hypertrophy of cell lining lymphatic sinuses. Sinuses will be hypertrophic and hyperplasia of the macrophages. Okay, so in this case, macrophages will be moving. There are variants of the paracortical lymphoid hyperplasia. One is angioimmunoblastic lymphadenopathy, then dermatopathic lymphadenopathy, and dilating lymph node, that is post-vaccine. So this is the paracortical area which there is a hypertrophy. Okay, this space is enlarged after and T cells are present in that. So now third is sinus histiocytosis. It is also called as a reticular hyperplasia. Okay, so histiocytes will be increasing. So what are the causes? So nodes are draining inflammatory regions, and there are nodes of draining inflammatory regions. There is some infection somewhere outside, and these are because of that that the sinus histiocytosis. Post-reaction to the malignant tumors like axillary node and CSH and Rosai Dorfman syndrome, Rosai Dorfman disease. This is also sinus histiocytosis. Microscopically, the expansion and distension of the sinus, the name suggests there is distension of the sinus. Proliferating endothelial cells, there is hypertrophy and histiocytes and hypertrophic histiocytes and plasma cells. So this is the sinus histiocytosis. You can see the sinus spaces that are enlarged size. This is also sinus space. You can see large enlarged sinus spaces as well. Now, this is chronic and acute lymphadenitis over. Now we'll see some of the few most common lymphadenopathies. So first is HIV related lymphadenopathy, which is very important. So what is HIV related lymphadenopathy? Presence of lymph nodes of more than 1 centimeter. Okay? The size of the lymph node is enlarged, and there are 2 or more extra inguinal sites. Okay, so inguinal sites are generally not considered because inguinal lymph nodes are normally present in some patients because of some wounds in their leg lower extremities. So if it is extra inguinal sites have 2 or more lymph nodes for more than 3 months without any other obvious cause, it's the earliest symptom of HIV. So the patient is having lymph nodes for 3 or more months without any cause, then we can suspect the patient of HIV. So what is the histology? How the lymph node in HIV lymphadenitis, how the lymph node will be? There are 3 stages for the lymph node: early stage, intermediate stage, and late stage. In early stage, the follicular hyperplasia indicates B cell proliferation. So there will be follicular hyperplasia which we have seen prior, and that indicates B cell proliferation. In initial stage, body will try to produce more amount of B cells. So there will be follicular hyperplasia. In intermediate stage, now body will not produce that much amount of B cells. So there will be combination of follicular hyperplasia and involution. The body is now failing to produce that much amount of B cells. And in late stage, there is follicular involution and lymphocyte depletion. The number of lymphocytes are decreased, follicles are decreasing. And the size of the lymph node is also decreased. So this is HIV related lymphadenitis. So what is the morphology of the lymph in HIV patients? So there are 3 stages: early, mid stage, and end stage. So what is early stage, which we have discussed? There is florid follicular hyperplasia. More amount of follicles will be present. That is more amount of B cells are present. That is also called as explosive lymphadenopathy. Okay, so the follicles will be dumbbell-shaped germinal center, less prominent marginal zone. Marginal zone will be less prominent, but the follicular germinal centers will be enlarged. Monocytoid B cell hyperplasia and multinucleated giant cells occasionally present. This is early stage, okay, in the HIV patient. Now, hello. Okay, so mid stage, can you hear me? You can switch on your microphone.
Yes, ma'am. Yes, ma'am.
So now the mid stage, that is what is mid stage? That is burnt out atrophic germinal centers. So germinal centers will be now the smaller in size that compared to early stage, and follicular hyperplasia either present or absent. It is a mid stage between the end stage and early stage, and slight plasma cytosis will be present. What is the end stage of the HIV patient? The follicular involution. So no number of follicles will be less, the size of the follicles will be small, and the lymph node will be smaller in size or shrunken. Okay, so this is the HIV lymphedema. So now you can see follicular lysis. We cannot see any follicles. Okay, clearly germinal centers are not present, and there is only this mental cells are present in this region. The lymphocytes are present. Okay, so this is follicular lysis. These are the chronic. This is the lymph node in HIV patients. Okay? Now we will see tuberculosis, which is the most common cause of lymphadenitis in India. So the lymph node will be enlarged. Uncut section. What we have discussed prior in tuberculosis, there is caseating necrosis in the lymph node. Cheese-like lymph node cut section will be like cheesy material. Okay, so this is the tuberculous lymphadenitis. Now see pulmonary in X-ray lung, we can see these are the lymph nodes. In this section also, you can see there are two lymph nodes, okay, round structures. So this is tuberculous lymphadenitis. Now what is microscopy? We have discussed and drawn many times in practical journals. So what is tuberculosis granuloma? So lymph node will also show granuloma with giant cells, undenucleated, horseshoe-shaped giant cells, epithelial cells, caseating necrosis, which is we have discussed prior in tuberculosis. Same all lymph nodes, tuberculous lymph nodes will have granuloma. This is a normal installation. Now one more condition which we see in lymph node, that is infectious mononucleosis. So what is the positive organism for infecting infectious mononucleosis? Is Epstein-Barr virus. Okay. So the lymph node will be enlarged and flooded by atypical lymphocytes. In infectious mononucleosis, these similar atypical lymphocytes are present in the blood also. In peripheral blood smear, also we can see these atypical lymphocytes which are present in lymph node also. Okay, which occupy the paracortical, that is T cell area. Occasionally, the cell resembles like a red string of cells. You will see now next lecture will be of neoplasia of the lymph node, and the lymphomas are discussed in that. And Hodgkin's lymphoma is the most common lymph node tumor. In that, we see red string of cells. They are characteristic of RS cells. These infectious mononucleosis cells, that is atypical lymphocytes, they resemble the RS cells of the Hodgkin's lymphoma. So this is an infective condition, and the RS cells which are present in Hodgkin's lymphoma is a malignancy. Okay, so you should be able to differentiate if it is infection or tumor. Now, one more lymph node disorder is cat-scratch disease. It is related to the cat, it is transferred from the cat, and it is self-limited lymphadenopathy, self-limiting. Okay, after some days, the lymph node enlargement will, the lymph node size will be reduced. It is caused by the bacterium Bartonella helper, primarily a disease of childhood. The regional lymphadenopathy, regional is only specific region is involved, that is either axilla or neck. So what is the microscopy in cat-scratch disease? Microscopically, initially sarcoid like granuloma. Granuloma will be there like a sarcoid disease. Okay, but they undergo central necrosis and associated with accumulation of neutrophils. So more amount of neutrophilic debris will be present in the cat-scratch disease. The microbes, that is the bacteria, is extracellular. So it can be visibly, we can see by silver stain or electron microscopy. So this is the infective cat scratch disease. Now one more condition we can see in the lymph node is leprosy. So it is also known as central disease. So the lymph node involvement by lepromatous leprosy, which is lepromatous leprosy, and the sinuses are massively dilated, and as a result of accumulation of foamy histiocytes. You can see foamy histiocytes, all these are histiocytes, and they have a foamy cytoplasm. Okay? So these are in foamy histiocytes are present in lepromatous leprosy lymph node. Now, SLE, systemic lupus erythematosus. So, in SLE, what we will see, there is a large accumulation of DNA containing basophilic material in the subcapsular space. Okay? In subcapsular space, there will be basophilic material present, that is SLE. So, now we have discussed most of the infection causes for lymphadenitis. There are a few other diseases like Castleman disease, which is present in HIV patients, in Kawasaki disease, which is seen in children, and now in corona patients also we can see Kawasaki disease in children. That is inflammation of lymph node because of the blockage of the artery, blood cells inside the lymph. So now we have done, now we will see lymphadenopathy. So there are other causes for lymph node enlargement. Okay? So infective, we have seen all these infective causes, that is acute is because of gram-negative organism, chronic, that is granulomatous, maybe tuberculosis, syphilis, leprosy, fungal, lymphogranuloma venerum, viral causes. We have seen infection mononucleosis, which is caused by Epstein-Barr virus. Post-vaccinal lymphadenopathy, HIV related, we have discussed. Immunologically, rheumatoid arthritis, Castleman disease, which is present in HIV patient, drug hypersensitivity. These are the causes for lymphadenitis, infective causes. And now, second is immunological causes, and third is tumors, neoplastic, that is Hodgkin's lymphoma, non-Hodgkin's lymphoma, ALL, that is acute lymphoblastic leukemia, and metastasis in the lymph node, primary lesion at various sites. So this topic will be your next lecture, okay, neoplastic leukemia. So now what are the investigations we will do in patients of lymphadenitis, okay, lymphadenopathy? So we will do WBC count and blood culture, fine needle aspiration cytology. Fine needle aspiration cytology, by the syringe, we take out the material from the lymph node and we spread that material on the slide, and then we try to find out the cause of the lymphadenitis. So this is fine needle aspiration cytology. And this slide, what we have prepared by this fine needle aspiration cytology, we do H&E staining to see the normal structure of the lymph node, pap smear, Florence stain for tuberculosis, Gram stain for any other bacteria, Giemsa stain, AFP culture for leprosy. Also we do ZM stain, AFP culture for tuberculosis. Sometimes on FNSC we cannot find the cause of the lymph node enlargement. So that time we do the biopsy of the lymph node. Mainly biopsy is important in the tumors, like Hodgkin's lymphoma, non-Hodgkin's. X-ray test we do specifically for tuberculosis, and Mantoux test also we do for the cervical lymphadenopathy and lymph node. So this is the procedure of FNSA lymph node. This is the procedure. So this is the syringe, and there is a lymph node enlargement. So the lymph node is fixed by the thumb and index finger, and by the syringe we take out the material, and that material is spread on the slide, and we see the histology of the lymph node. So this is the OPD procedure. We don't have to admit the patient for this how to find out the cause of the lymph node. Okay, so now we have finished with the topic of lymph node. So now the next topic for today is spleen. So spleen, we will start with spleen. So spleen is the largest lymph organ on the left side of the abdominal cavity. Spleen contains large quantity of blood, okay, that expelled periodically into the circulation by action of smooth muscles in the capsular surface. So amount of blood will be present in the spleen. now we will see the normal histology of the spleen. So this is a hilum, and hilus part there are vessels coming inside. These are the trabecular arteries which are present in the trabeculum. Then there is central artery, and when the blood is present, that is called as the red pulp, and the white pulp is the area where the follicles or germinal centers which are present here. This is lymphoid follicles are present. Then there is this is a penicillary arterioles. Then the efferent system will start, that is splenic cords and venous sinusoid, and then this is trabecular vein. So this is a normal vein histology. What we will see, so now this is the spleen. You can see the red pulp, that is the red area that is congested. Arteries will be present. White base are the germinal centers, and lymphocytes are present. So what are the structures? Red pulp, white pulp, lymphatic follicles, germinal center, central artery and vein, trabecular artery and vein, and venous sinuses. There are the sinuses, that is spaces. Spaces present in this. So now we will see the conditions. What are the conditions which we see in the spleen? So first and important which we have seen is congestive splenomegaly, that is also called as CVC spleen. We have discussed this prior in general pathology, that is chronic venous congestion of spleen. So what is the cause for CVC spleen? It's right heart failure. Right heart failure will give CVC spleen, CVC liver, CVC lung. So this lung is left heart failure. So this is CVC spleen. So how the gross organ will be enlarged? The spleen will be enlarged. The capsule is thickened and tense. On cut surface, the spleen will have firm and congested appearance. Congested because there is more amount of blood will be present in the spleen. So what is the microscopy? The thickened capsule and trabeculae will be present. Atrophic lymphoid follicles. Because of the congestion, the follicles are atrophic, and more amount of blood is present in the spleen. So hemosiderin will be increased in the spleen. So there will be hemosiderin, iron, macrophages. Then dilatation and congestion of splenic sinusoid. Because of the congestion, the sinusoidal spaces are dilated. And gamma antibodies, we have discussed, CVC spleen has gamma antibodies in the because of the secondary injury. So what are the gamma antibodies? These are iron and calcium containing fibrotic nodules. So CVC spleen, this is congested, enlarged spleen. And now we will see a microscopy. This is the calcium and iron deposited in the spleen. They are called as gamma antibodies, which is specifically present in the CVC spleen or congested splenomegaly. Next condition which we see commonly in the spleen is splenic infarct. Infarct is blood supply to the spleen is hampered. So what are the causes why the blood supply is hampered? Either there is occlusion of splenic artery, there can be thrombosis, embolism, which arise from the neural thrombi in left auricle or ventricle or vegetation on the wall. Infiltration with leukemic cells, that is why there will be occlusion because of the leukemic cells present in the vessel. Obstructions of the leukemic, such RBC in the sickle cell anemia. Sometimes in post-mortem cases, while we can see the spleen slide, and in that RBCs are sickle shaped. So then we can diagnose the cause of death can be sickle cell anemia, and the vessels are blocked. In spleen, we can see the RBCs with malarial parasites or leishmaniasis, also Leishmania donovani body can be present in the spleen, RBCs which are present in the spleen. So now what is the gross for the splenic infarct? Infarcts are conical or irregular in shape with a base at the capsule of capsular surface. It is a conical shape and the base at the capsule. Either pale or red infarct. Pale infarcts are surrounded by hyperemic border. So the border will be dark red in color in pale infarct. What is the microscopy? There will be coagulative necrosis. You will see just the pink area. There is no nuclear morphology will be present in that area. That is called as splenic infarct. So this is the morphology of the spleen. You can see pale infarct. Now we have discussed splenic infarct and CVC spleen. So now we will see the general causes for splenomegaly. Splenomegaly is the most important question in pathology and in medicine. Causes of splenomegaly. So we will discuss this. There are different types of causes. Either hematological diseases, hemodynamic, that is because of the blood circulation problem, infection, storage diseases or metabolic diseases, neoplasia, that is tumor, trauma, and connective tissue disease. The generalized causes for splenomegaly. Now we will discuss each of the cause. So what are the hematological causes for splenomegaly? That is, spleen is enlarged. So anemia, what are the diseases like sickle cell disease, thalassemia, hereditary spherocytosis, pyruvate kinase deficiency, thrombotic thrombocytopenia purpura, TTP. These are the causes for splenomegaly, hematological causes. Now we will see hemodynamics. The first, most important, cirrhosis, which we have discussed prior in my lecture, cirrhosis, that causes portal hypertension, congestive splenomegaly, that is CVC spleen, or Banki syndrome, that is idiopathic condition that can lead to enlargement of spleen, splenic vein obstruction, portal vein obstruction, or right heart failure. These are the hemodynamic causes for spleen enlargement. Now there are infections, viral, bacterial, parasitic. What are the viral infections? Epstein-Barr virus causes infectious mononucleosis, which is the commonest cause for infective splenomegaly. AIDS, cytomegalovirus, herpes simplex virus, and rubella. Bacterial causes: tuberculosis, tularemia, subacute bacterial endocarditis, typhoid, brucellosis, syphilis, and other infective causes. Fungal histoplasmosis, which is common, and candidiasis. Parasitic, that is malaria. Malarial parasite can give splenic enlargement, and we can see the malarial parasite in the RBCs of the skin. Schistosomiasis, hereditary disease, and leishmaniasis, that is also called as Kala Azar. Leishmaniasis will have LD bodies in the spleen, and rickettsial, that is typhoid. So these are the infective causes. Now we'll see neoplastic, which are non-hematological neoplastic. That is lymphoma, commonest for metastasis either from breast, lung, colon, ovary, or melanoma. Hemangioma, that is blood-related tumor, but it is benign. Hemangioma, it is benign tumor. Angiosarcoma is a malignant tumor of the blood vessel. Now neoplastic, but hematological. Okay, so leukemia like CML, chronic myeloid leukemia, CML, polycythemia rubra vera, multiple myeloglobinuria, myelofibrosis, extramedullary hematopoiesis. What is marrow has a group, extramedullary hematopoiesis, that is production of blood cells, that is RBC, WBC platelets, are not taking place in bone marrow. They are producing from spleen. So there is extramedullary hematopoiesis and osteoporosis. So these are causes for splenomegaly. There are various storage disorders. These are the genetic conditions because of which we can see the splenomegaly, either Gaucher's disease, glycogen storage disease, mucopolysaccharidosis, Niemann-Pick disease, hemochromatosis, amyloidosis. So amyloidosis, there is an MCQ question, stago spleen and larger spleen. So what is a stago spleen? That is, the appearance of the spleen is like stago grain, sabudana. The spleen will look like the stago grain. And why is stago spleen called? What the histology? So there is amyloid deposit limited to the follicles. So follicles will have amyloid deposit. So what is Lardashian spleen? That amyloid is deposited in the wall of the splenic sinus, right? And it does not have amyloid, won't be there in the follicles. It is present in the wall. So there are two different types of spleen, which we splenomegaly in amyloidosis. Stago spleen and Lardashian. Now there are the storage diseases we have discussed. Now other conditions like trauma, hematoma, pseudocyst, connective tissue disorder, rheumatoid arthritis like juvenile rheumatoid arthritis, Hypothyroidism syndrome, Still's disease, or SLE, that is systemic lupus erythematosus. All conditions will show splenomegaly. Okay, so this is the clinical position where we can see the spleen enlargement. This is massive splenomegaly. The spleen is enlarged, and this boy he is having ascites. So now we will see degree of splenomegaly. So they are differentiated on mild, moderate, and massive according to weight of the spleen. So if it is a weight of the spleen is less than 500 grams, it is mild. 500 to 1000 grams is moderate. More than 1000, it is massive. So what are the causes for mild splenomegaly? That is CVC, chronic venous congestion, acute malaria, typhoid fever, and endocarditis. Moderate is cirrhosis and lymphoma. Active splenomegaly, which we can see in CML, chronic myeloid leukemia. Storage diseases, chronic malaria, malaria which is present since long. Acute malaria will have mild symptoms. Chronic malaria, leishmaniasis, which we have told you, leishmania don't body to represent total venous obstruction. So these are the degree of pneumonia. So now this is the spleen and kala azhar, that is leishmania. What we will see, these are leishmania donomani bodies. These are the bodies, they will have a shape like a diya. They are purple in color. Kala azhar. Now we will see main storage disorder, that is Gaucher disease, because of which we will see splenomegaly. So the Gaucher disease is a spectrum of autosomal recessive diseases resulting from mutation in a gene encoding glucocerebrosis. So mutation in the glucocerebrosis is Gaucher disease. It is the most common lysosomal storage disorder. Glucocerebrosis derives from the cell membrane of aging cells that accumulate in phagocytes throughout the body and central nervous system. So, according to that, they are divided into three types: 1, 2, and 3. So, where there is lipid accumulation, according to that, we divide them into three types. So, type 1 is non-neuropathic. So, that indicates non-neuropathic CNS is not involved. So, only spleen and skeletal system will show Gaucher cells. Type 2 is neuropathic. So, CNS will show Gaucher cells. And if the patient will have early death. And type 3 is between the 1 and 2. These are the three different types of Gaucher disease. Gaucher cells which are present in the spleen. So what are the Gaucher cells? How they will see? They will look. The cytoplasm of the Gaucher cells will look like crumbled tissue paper appearance. Okay? So these cells will have crumbled tissue paper appearance. These are called as Gaucher cells. They will be present in the spleen. Now, what are the investigations to do in splenomegaly? Okay, so we have to find out the cause for splenomegaly. So, according to that, we have to do various investigations. So, we will do abdominal USG, MRI scan, full blood cell RBC count, full blood count, reticulocyte count, then hemoglobinopathy, any sickle cell disease, thalassemia. So we have to find any hemoglobinopathy present in the system. Renal function test to detect cirrhosis, virology, microbiology for any infection, serum protein electrophoresis in conditions like amyloidosis or myeloma. Then leukemia we have to rule out, lymphoma we have to rule out, liver and spleen scan we can get done. Then if we are not able to find the cause, we can do liver biopsy, bone marrow